Very good evening to all of you. On behalf of Heartlines, the Voices of Cardiac Anesthesiologists and IACTA West Bengal, I warmly welcome all of our faculty members, our colleagues, our seniors, our postgraduates, postdoctoral students, and all of our friends joining us from different part of our country. So it's a privilege to begin another exciting mini series. This time we are focusing on the pediatric cardiac anesthesia, a field that continuously challenges us to combine the scientific knowledge with precision, the teamwork, and the compassionate care. We are delighted to start this journey with the episode 1, that is the perioperative management of the AVSD. The atrioventricular septal defect is a complex congenital cardiac lesion that demands meticulous perioperative planning, a sound understanding of the physiology, and a close collaboration between the surgeons, cardiologist, intensivist, perfusionist, and the cardiac anesthesiologist. Today's session aims to bridge the gap between the theory and the real world practice by discussing the practical approaches, evidence based management, and the valuable clinical insights. We are truly honored to have with us Dr. Soumitra Mukherjee, an accomplished clinician and a teacher. His extensive experience in pediatric cardiac anesthesia will undoubtedly provide us with the practical strategies and the pearls that we can apply in our day-to-day practice. I encourage everyone to actively participate, to ask questions, and to make this an engaging academic discussion. Learning becomes meaningful when the knowledge is shared and the experience is exchanged. With a great pleasure, I now invite Dr. Soumitra Mukherjee to deliver today's talk on perioperative management of AVSD. So, sir, the virtual platform is all yours. Thank you so much.
Good evening, all. First of all, thank you to the West Bengal ACTA committee, particularly Dr. Mona Lisa, for giving me this opportunity to discuss the topics which are very relevant, not only for the theoretical aspect, but in our day-to-day cardiac anesthesia practice, the management, anesthesia management of different types of complex congenital heart disease. So without any delay, let me allow to start the today's session, which is the perioperative management of atrioventricular septal defect. Initially, it was known as also atrioventricular canal defect, but this term is now obsolete all over the world. The actual term is atrioventricular septal defect. What is the definition of atrioventricular septal defect? Atrioventricular septal defects are characterized by defects in the atrial and ventricular septum immediately above and below the atrioventricular valves, that is the tricuspid and mitral valves. Sorry. So as we know that normally there is difference. Just a moment. Sorry. So normally what happened, there is different tricuspid valve and mitral valve. Now tricuspid valve has 3 cusps and the mitral valve has 2 cusps. But in atrioventricular septal defect, in the complete category, the complete atrioventricular septal defect is having 5 different leaflets all together. There is no difference between the tricuspid and the mitral valves. So what happens in AVSD? I mean, the complete AVSD. It is a 5-leaflet atrioventricular valve which is having a single fibrous ring, that is the annulus, that lies at one horizontal level in the ventricular mass. So within the ventricular mass, there is only single annulus supporting 5 cusps and at the same level. Normally, the mitral and tricuspid valve, they do not placed at same level. A left lateral leaflet is housed exclusively in the left ventricle, and the right inferior leaflet and the right anteroposterior leaflet are housed exclusively in the right ventricle. The other 2 leaflets are designated as anterior and posterior bridging leaflets. So, this is the picture showing how it looks, complete AV septal defect in LV angiogram. A very characteristic feature of LV angiogram of a patient with complete AVSD is gooseneck deformity. It is an anatomical deformity. The abnormally positioned elongated left ventricular outflow tract together with the anterior superior position of the aortic valve and the apical position of the deficient inlet septum results in a gooseneck deformity. So to have this gooseneck deformity, we require certain anatomical features. Number 1, elongated left ventricular outflow tract. The LV outflow tract is elongated in AVSD and also it is abnormally positioned. Number 2, the aortic valve is also abnormally positioned in more anterior superior position. And number 3, there is deficiency in inlet septum of the IVS. It is more apically placed. So all these anatomical features together form the gooseneck deformity. And this gooseneck deformity is viewed either in echocardiogram or in LV angiogram. So coming to the embryology, why embryology is important? Because in DRNB exam, in final theory exam, the embryology of AV septal defect, they do appear in exam, in theory question. So I have put this slide intentionally to discuss about the embryology of the AV septal defect. The atrial septum is initially partitioned by a thin membrane, which is also known as septum primum, that appears to grow towards the region of the endocardial cushions from the roof of the atrium. So endocardial cushion is being placed between the common atrium and common ventricle. Now, from the roof of the common atrium, a partition known as septum primum is growing towards that endocardial cushion. Concurrent with atrial septation, thickenings of the subendocardial tissue called endocardial cushions develop in the dorsal and ventral walls of the heart in the region of AV canal. AV canal is in between is a region in between the atrium and ventricle, and there the endocardial cushion is placed. The endocardial cushion is growing from the dorsal end as well as the ventral end. I mean the ventral and the dorsal walls of the ventricle. The picture I will show later. The AV endocardial cushion now grow toward each other and they fuse, dividing the original AV canal into right and left side. At the same time, the endocardial cushion tissue grows in an upward direction to meet the primum septum and to close the intervening space. So, the AV cushion, which was placed in the region of AV canal, number 1, it is growing to each other to fuse with each other, at the same time growing upwards to fuse with the septum primum. Now, these cushions give rise to the inferior portion of the atrial septum as it is going upwards from the roof. The rest of the component of the atrial septum is going downwards. So it is forming the inferior portion of the atrial septum. The ventricular septum, particularly the inlet portion, which is placed immediately below the tricuspid valve, and the septal leaflets of both the mitral and tricuspid valve. Therefore, abnormal growth in this region produces a deficiency in the lowermost part of the atrial septum, in the inlet portion of the ventricular septum, and problem within the leaflets of the mitral and tricuspid valves. Now look at this picture. On the left hand side, you could see that initially there is a primitive ventricle. There is no gap or septum within this ventricle. From the AV canal portion, you can see that the dorsal AV cushion and the ventral AV cushion, they are approaching to each other. Ultimately, they fused with each other, divide the primitive ventricle into left side and the right hand side. At the same time, on the right hand side of this slide, look at this picture. These dorsal and the ventral AV cushions prominent, they not only grow towards each other, but at the same time they are going upwards to meet the septum primum to close the common atria, as well as going downwards to form the inlet portion of the ventricular septum. Now you can understand how the inlet portion of the ventricular septum develops, how the inferior portion of the interatrial septum develops, and how the different mitral and the tricuspid valve develops, and the problem within this region, how they develop the AV septal defect. Coming to the classification, it is very important. According to the classification, the management strategy, the preoperative optimization, the surgical planning, and the postoperative management completely differs. So, depending upon the anatomical components, the two major types are partial AV septal defect and complete AV septal defect. Now, what are the components of partial AV septal defect? When there is ostium primum atrial septal defect and presence of two distinct mitral and tricuspid atrioventricular valve, particularly the distinct annulus, and presence of cleft mitral valve comprises the partial AV septal defect. So, ostium primum atrial septal defect, cleft mitral valve, and two distinct mitral and tricuspid valve annulus is partial AV septal defect. Now, what is adding in complete one? Apart from this ostium primum ASD, there is always presence of inlet VSD, and there is no presence of no two distinct annulus. There is a common atrioventricular valve with a single annulus. Now, there is another subclassification of the partial AVSD, that is transitional AVSD. Here, along with ostium primum ASD and cleft mitral valve, another feature is that presence of small inlet VSD, but it is almost in every cases is restrictive VSD, as it is partially occluded by dense chordal attachment of the septum. Another subvariety of complete AV septal defect is intermediate AV septal defect. Here, a common single annulus in the AV canal region is absent, and in place of that, there is distinct right and left AV valve orifices is present, although it is having a common annulus. Common annulus is there, but two distinct different valve orifices are there. Let me show you the picture. On the extreme right position, it is a picture of partial AV septal defect. You can see that there is presence of only ostium primum ASD. Type B is the transitional, that is, apart from ostium primum ASD, there is presence of a small inlet VSD. Type C is the intermediate one. You can see that presence of ASD and the inlet VSD, there is a common common annulus, but distinct mitral and tricuspid valve orifice. And on the extreme left portion, that is the type D, it is the picture of complete septal defect. You can see that presence of ASD, presence of inlet VSD, and a common orifice for both tricuspid and mitral valve having 5 leaflets. So, what is cleft mitral leaflet? Commonly, it is seen in anterior mitral leaflet. Cleft is actually the meeting point of left halves of anterior and posterior bridging leaflets. It is a type of commissure. The cleft of AV septal defect is directed towards mid portion of the ventricular septum. You can see that on the left hand side, it is a picture of transthoracic echocardiogram. The arrow portion is highlighting the portion of cleft within the AML, and on the right hand side, the aesthetics is showing within the transesophageal echocardiography. It is the deep transgastric view, the short axis view, the presence of cleft within the anterior mitral leaflet, within the ventricular septum. So, number 2 classification is depending upon the size of the ventricular chamber. Again, it is very important because the surgical plan of management will definitely be guided by the balance. It is of 2 types, either balanced AV septal defect or unbalanced AV septal defect. Now again, unbalanced AV septal defect is of 2 types, right dominant type and the left dominant type. Unbalanced AV septal defect with right dominant type usually associated with arch hypoplasia or coarctation of aorta. The left one is usually associated with pulmonary stenosis or pulmonary atresia. The decision between balanced and unbalanced ventricles in borderline cases is best done by using AVVI, that is the atrioventricular valve index. For a balanced AV septal defect, AVVI should be between 0.4 to 0.6. If it is less than 0.4, it is known as right dominance, and if it is more than 0.6, it is known as left dominance. So how the AVVI is being calculated? From the echocardiography, first we have to calculate the circumference of the common atrioventricular valve orifice. From the short axis view, the subcostal or the parasternal short axis view, we can get that view, and from there we can calculate the circumference. For a better result, we can take 3 or 4 results to make a average. After getting that value, we have to calculate the distance from that orifice to the tip of the inlet septum. Definitely there will be a gap because there is inlet VSD. So that gap between the common orifice and the inlet tip of the inlet septum, and it is then the value of circumference of the common valve and the value of the distance between the orifice and the tip of the inlet septum will give you the value of AVVI. This is the picture showing how it looks. The right dominant type of complete AV septal, unbalanced AV septal defect, and left dominant type of unbalanced complete AV septal defect. The third category of classification is also known as Rastelli classification. It is of 3 types. Type A is where the superior bridging leaflet attaches to the ventricular septum. Type B is the superior bridging leaflet attaches to a septal papillary muscle on the right side of the ventricular septum. And type C is the superior bridging leaflet extends to the anterior papillary muscle directly within the right ventricle. There is no attachment within the ventricular septum. Coming to this picture, on the left hand side, the picture A is the type A, and in the middle type B, that is both in the septum as well as in the papillary muscle. and type C is the where it is the complete attachment of the septal bridging leaflet with superior bridging leaflet within the ventricular capillary muscle. No connection with the ventricular septum. So in some situations, there are certain association of episeptal defect, means that certain other co-conditions associated along with episeptal defect. Number one, Down syndrome. So whenever a patient comes with Down syndrome and episeptal defect, we have to keep in mind that the other features, when we are dealing with a child with Down syndrome, the airway management should be planned accordingly. The second association could be either asplenia or polysplenia. Dijot syndrome is commonly associated. If a patient with Dijot syndrome and episeptal defect comes for the surgery, then definitely in the perioperative period, we have to think about the hypocalcemia. So calcium infusion is mandatory. Tetralogy of Fallot is definitely sometimes associated, which is also known as tit canal. That is, there will be features of cyanosis in a patient of episeptal defect, and definitely as there is tetralogy of Fallot, so pulmonary overcirculation because of left-right shunt and pulmonary excessive blood flow will not be there in complete episeptal defect. So there will be no sudden rise of peer pressure in a patient of tit canal. Sometimes DORV or TGA can be associated with episeptal defect also. So what is the pathophysiology? Three major hemodynamic disturbances in episeptal defect are: number one, interatrial shunting; number two, interventricular shunting; and number three, AV valve dysfunction. So shunting is being happened both at interatrial level as well as in interventricular level in a complete episeptal defect, but only at interatrial level in case of partial episeptal defect. Now, as there is less shunting in partial episeptal defect through only the atrial septal defect, the partial episeptal defect either could be asymptomatic or symptomatic. Even if they are symptomatic, the symptoms are mostly because of atrial septal defect. Patients often develop congestive heart failure in infancy in complete episeptal defect. In partial episeptal defect in infancy, heart failure is very rare. Now, what about the mitral insufficiency? The degree of mitral valve insufficiency plays a large role in determining the severity of the lesion. Why? Because if the intensity of MR is very high, then definitely in a patient of partial episeptal defect, patient can develop congestive heart failure in earlier age. What about the pulmonary hypertension? Pulmonary hypertension is common in complete episeptal defect because of torrential blood flow through the pulmonary circulation, both by interatrial defect as well as the interventricular shunting. That excessive pulmonary blood flow or pulmonary overcirculation is causing pulmonary histologic changes in the form of pulmonary vascular changes. So initially the pulmonary hypertensive episodes will remain reversible stage, but as the child is growing, it becomes irreversible because the histologic changes becomes irreparable and irreversible. The physiologic consequences of an ostium primum atrial septal defect depend on its size and on the functional state of the left atrioventricular valve, as I mentioned about the mitral insufficiency. When the defect is non-restrictive, the left atrium decompresses as it receives regurgitant flow from the left ventricle. When the atrial septal defect is restrictive, the clinical picture resembles isolated mitral regurgitation, definitely because of cleft in the AML. A non-restrictive ventricular septal defect sets the stage of pulmonary vascular disease. I have already mentioned about the PH component in complete septal defect. The physiologic consequences of a complete atrioventricular septal defect are the sum of the non-restrictive interatrial and interventricular communications and the degree of incompetence of the left and right components of the common atrioventricular valve. There is huge regurgitation from the ventricle to the atrium as well as excessive blood flow within the pulmonary circulation. Now, coming to the guidelines. This is the guideline of European Society of Cardiology about the adult component of the AV septal defect. To some extent, we can apply this guideline to the pediatric age group also. So, about the complete AV septal defect, what they are telling, the surgical repair is not recommended in patients with Eisenmenger physiology and patients with PH where the pulmonary vascular resistance is more than equals to 5 Wood units and patient is presenting with desaturation on exercise. So in this scenario, the surgical repair is contraindicated. About the partial one, surgical closure is recommended in patients with significant RV volume overload and should only be performed by a congenital cardiac surgeon. For AV valve regurgitation, the valve surgery, preferably the AV valve repair, is recommended in symptomatic patients with moderate to severe AV valve regurgitation, and in asymptomatic patients with severe left-sided AV valve regurgitation, valve surgery is recommended when certain parameters are met. Number one, LV end systolic diameter more than 45 millimeter and LV ejection fraction less than 60%. Mentioning that other causes of LV dysfunction are excluded. And the last one is that in asymptomatic patients with severe left-sided AV valve regurgitation, preserved LV function, that is end systolic diameter less than 45 and ejection fraction more than 60%, high likelihood of successful valve repair and low surgical risk. The intervention should be considered when the atrial fibrillation or systolic PA pressure is more than 50 millimeter mercury. So even if the LV function is preserved, the surgical intervention should be done when there is atrial fibrillation or the systolic PA pressure is more than 50. Coming to the clinical examination part. Whenever you are examining the child, there will be certain parameters like visible left parasternal heave with palpable RV lift. On auscultation, there will be hyperactive precordium because of congestive heart failure, particularly incomplete one. Prominent S1 with fixed splitting of S2, just like ASD. There could be signs of pulmonary edema. Patients with complete AV septal defect usually present with features of heart failure. And definitely in both complete and partial AV septal defect, there is always risk of subacute bacterial endocarditis. The ECG is very significant. There will be features of marked RV hypertrophy with prolonged PR interval. Sometimes LV hypertrophy will be present. So biventricular hypertrophy is very common in complete AV septal defect. What the chest X-ray is showing, number one, cardiomegaly, number two, prominence of main pulmonary artery shadow, and number three, increased pulmonary vascular markings. What about the echocardiogram? There will be loss of offsetting of atrioventricular valve. What does it mean? It means that normally in normal heart, tricuspid valve and mitral valve are placed not at the same level. Tricuspid valve is placed more apically and mitral valve is placed a little bit higher in normal one, but and it is known as the offsetting of atrioventricular valves. But this offsetting, which is a normal pattern, is lost in AV septal defect. Here, both the mitral valve and the tricuspid valve are placed at the same level. Now, number two, there is deficiency of inlet portion of the ventricular septum. Number three, presence of common atrioventricular valve fibrous orifice. Number four, abnormal morphology of atrioventricular valve cusp. Number five, abnormal position of the papillary muscles, particularly in type C, Rastelli type C, complete AV septal defect. And the last one is longer left ventricular outflow and anterior unwedged position of the aorta, which is also known as gooseneck deformity. Now, how it looks? The left one is the 2D picture, and when you place the color flow, it is the picture of complete septal defect. You can see that there is absence of atrial septum and absence of ventricular septum, and there is common orifice of the tricuspid valve and the mitral valve. This is the video of a complete episeptal defect. Look at this video. There is absence of ventricular septum, absence of interatrial septum, and there is common valve through which blood is passing from the atrium to the ventricle. Common valve orifice. So, what are the surgical techniques? What are the options we have? For the partial episeptal defect, the atrial septal communication is closed, just like closure of ASD, with either a pericardial patch or a PTFE patch. The cleft in the anterior leaflet of the mitral valve is repaired, generally with non-pleated interrupted fine sutures. Why? Because if the pleated one is being used in later on, there will be development of calcification within the mitral valve leaflet. For the complete episeptal defect, repair must be done prior to the development of irreversible pulmonary vascular obstructive disease, that is fixed component of raised PVR, and preferably it should be done before 6 months of age. Principles involving the closing of the ventricular septal defect and subdividing the common atrioventricular valve into a left-sided and a right-sided AV valve, suspending these newly created valves from the top of the VSD patch. And sometimes two ventricular repair may not be possible, particularly in patients with unbalanced episeptal defect. The complete episeptal defect with aortic outflow obstruction resulting in a hyperplastic left ventricle may need to be palliated with Norwood type procedure. We all know that if the corrective surgical procedure is not to be performed, we have to go for the palliative procedure, the single ventricle pathway. The other variant of unbalanced episeptal defect are eventually staged to a univentricular fontan circulation. Sometimes, even if you see that the surgical lesion is surgically correctable, but because of some contraindication, you cannot go for early repair. I mean, preferably within the first 6 months of age. There, you have to reduce the pulmonary circulation, because at any cost, you have to check the pulmonary blood flow. How could you do it? By either PDA ligation and or PA bending. And after that, whenever the contraindication is gone, you can go for the corrective repair. What are the anesthetic consideration? I'm not going into details of the anesthetic consideration, because the basic part of management of a acyanotic congenital complex congenital heart disease remains same in these patients also. But some points particular to AV septal defect you have to keep in mind. Whenever we are anesthetizing a child with complete AV septal defect or a partial one, maintaining a balance between the ratio of PVR and SBR is of utmost importance throughout the perioperative period, because limitation of the pulmonary blood flow is very important. Because during the perioperative period, there are certain situations when the PVR is reduced, so pulmonary blood flow, which is already excessive, will become higher. So there will be chances of sudden rise of PA pressure, even PA crisis. T is definitely very helpful both in the preoperative period as well as in the postoperative period. The fluid overload should be checked, should be corrected, and rather avoided in the pre-CP bypass period, especially patients who are having congestive heart failure symptoms and were on diuretics. Inotropic support upon weaning from CV bypass is mandatory. Now, the choice of inotropes, it varies according to the institution, but mostly what the pediatric cardiac anesthetists they follow is number one, adrenal infusion and either dopamine or dobutamine. But along with them, use of milrinone is very important. Rather, milrinone is absolutely mandatory for use while you are coming off from CV bypass. And during the perioperative period, particularly while coming off and after coming off from the CV bypass, there could be episodes of pulmonary hypertensive episodes. It should be corrected in various ways, either by balancing the ventilatory parameters. Some definite drugs are there. So management of pulmonary hypertensive episodes and the management of PA crisis, I will discuss in some other topics, maybe in ventricular septal defect. Complete heart block is very common in repair of particularly complete AV septal defect, because the presence of inlet ventricular septal defect is very close to the conduction system. So whenever the surgeons are taking sutures or handling that particular region, there is every possibility of development of complete heart block while coming off. So it is better to have AV sequential pacing. So what are the parameters we have to check in the pre-CV bypass period? Number one, the type and the extent of atrial communication. Next is the type and extent of the ventricular communication, the atrioventricular valve morphology and function, the shunting pattern and the AV valve regurgitation, then commitment of the AV junction to the underlying ventricular mass and the size of the ventricle, whether it is balanced or unbalanced, because according to that, the surgical decision will completely changed. And definitely whether there is any associated cardiac anomalies are present, like tetralogy of Fallot. And most importantly, whether there is any additional VSD apart from that inlet VSD is present or not. So all these parameters are actually to guide the surgeon about their surgical plan of management. The mid-esophageal fourth chamber view demonstrates the relationship of the AV valve to each other and to the septum. In this defect, the AV valves insert onto the interventricular septum at the same level, as I have already mentioned. Scanning of the entire AV orifice from a transgastric or deep transgastric plane displays the 5 leaflets of the common AV valve and the cleft between the left-sided components of the bridging leaflets. Now, ostium primum ASD, again, it can be seen based in mid-esophageal fourth chamber view as well as in the bicaval view. For inlet VSD, mid-esophageal fourth chamber view is the best view. In the post-CV bypass period, what are the parameters we should look for in the ICU or in the OT just after coming off? Number one, residual atrioventricular valve regurgitation or stenosis has been developed or not. Number two, residual or additional VSD. Number three, LVOT obstruction. And number four, myocardial contractility. What are the situations we may face in the post-operative period? In the post-operative period, it is desirable to have PA line and the LA line. Now, PA line and LA line, they are also important in the post-operative period while you are coming off. Both PA pressure and LA pressure will help us to know about the situation, about the PA pressure as well as the myocardial contractility. So these two lines are also significant for monitoring purpose in the ICU also. If PA crisis is developed in the post-operative period, that can be happened also. It should be managed accordingly. I've already mentioned that different types of dysrhythmias are very common, so that should be managed accordingly. if there is complete heart block, AV sequential pacing, the jet junctional tachycardia managed either by cooling or by amidon infusion, like this. Low cardiac output syndrome. It is also again common scenario. The causes of low cardiac output syndrome in the postoperative period. Number one, inadequate myocardial protection during the intraoperative period. Number two, increased LV afterload. Now, why there will be sudden increase in LV afterload in the postoperative period? As because in the preoperative period, LV was ejecting blood either through incompetent AV valve or through the VSD. Now, in surgical repair, we have closed both the VSD as well as we have repaired the mitral insufficiency. So now the LV has to eject the blood through the aortic valve only. So there will be sudden rise of LV afterload, and that can cause the low cardiac output syndrome. To combat this, it is preferred to keep the inotropic support up to 48 hours, particularly the millinol infusion. Severe residual mitral insufficiency could be there, and that can also cause low cardiac output syndrome. Now, this severe residual MR, it is either could be because of anatomically inadequate repair or left ventricular dysfunction. Although it is uncommon, but whenever it is present, it should be addressed definitely. In case of anatomically inadequate repair, that patient again has to be transferred to the theater and it has to be repaired accordingly. And if it is because of left ventricular dysfunction, the inotropic support should be continued till the dysfunction is gone, the low cardiac output period is over. The diuretic infusion should be started and fluid should be restricted. If required, mechanical ventilation should also be continued. That's all. Thank you.
Hello. Hello. Any questions? Any questions or comment or anything to suggest?
See, for the students, atrioventricular septal defect anesthesia management question comes in theory exam, including the embryology. There could be a long case of AV septal defect, and the important one is the TE views. They will give you the loops of complete AV septal defect in the exam. So you have to identify that loop, and from there the question will go on. So for theoretical purpose, for practical purpose, as a long question, and echo loops, AV septal defect is very important.
Yes, indeed. The AV septal defect is so important, and the students, specifically the students, has to learn it by heart. Thank you, Soumitra. It's an excellent presentation, and it's a really enriching session for all of us. Your practical approach. Definitely. Please go on asking questions.
Very concise and very precious.
Is it Sohelda?
Yeah, yes.
Okay. Your name is not showing. Thank you, Sohelda.
Yeah.
I can recognize your voice.
What about keeping a PFO? Should it be regularly done?
Yeah, that's a very important aspect. Very important aspect. It depends upon the surgeon's choice. Some surgeon, they intentionally left a PFO open for complete septal defect with severe pH, particularly if it is being operated at after 6 months. So there is very high possibility of development of PA crisis and sudden rise of PA pressure in the post-operative period. That PFO will definitely help. But if surgeon is not very much willing to keep that PFO open, then they can keep it closed. But according to if you ask me, I think it is better to keep PFO open. But because later on, in later stages of life, it will get closed, and the chances of embolization through that PFO is very insignificant.
We regularly keep a small PFO. We do not put a
Yes.
LA line. We keep a PFO. That RA pressure in that case is almost equivalent to LA pressure.
See, LA line, why I'm telling you is important is that yes, you are right that to some extent RA pressure will guide you about the LA pressure. But if I have an option to keep LA line directly within the LA, the pressure which we are monitoring is definitely will give you the better idea.
Yes, I agree.
Because suppose what happens, you are giving infusion through the CVP line within the RA. You are giving fluid through that CVP line. So that pressure, I think, could be erroneous sometimes.
Right. I agree. But there is a fear also that
that placement of LA line is also very important. I mean, very interesting. Some surgeons, they put the LA line through the pulmonary vein. Surgically, they place that LA line, and in some institution, they used to put the LA line through the internal jugular vein. Means the internal jugular vein, they are placing that long line, and when the surgeon is opening the right atrium, definitely there is a communication between the right atrium and the left atrium. So whenever they are closing the ASD, through that ASD, they are keeping a small PFO, and through that PFO, they are placing that line from the internal jugular vein to the RA to the LA. And whenever the purpose of LA pressure monitoring is over, they can easily pull off that LA line in the ICU.
Right.
Any other queries or any comments? Shohil, thank you so much for your interaction.
That's all. Thank you, Soumitra.
Thank you, Shalda. Thank you.
So we also sincerely thank Dr. Soumitra. Thanks to all of the participants for your enthusiastic presence and active interactions. Your support is what makes this hotline it's so interactive and meaningful. So we'll be looking forward to welcome you again on the next Saturday at 7 p.m. for the next episode of this pediatric cardiac anesthesia mini series. So until then, stay safe, keep learning, and always have a beating heart. Thank you so much. Thank you and good night.
One request from my side, Monalisa ji, is that whoever is joining, either mostly for the students, please before joining, go through that chapter. It will be easier for you to understand whatever I am sharing with you, and then your understanding will be better, and the interaction between you people and me again will be helpful. So my request is that just go through that chapter just for once before joining this session. From now onwards, please try to follow that.
So what we can do that on Thursday or Wednesday, we could suggest the topic, and
Yes.
we can refer that this chapter you can read from this book,
Sure.
the page numbers or anything. So that will
Sure.
be easier for them and
Yes.
all of
Yes.
us also.
Yes.
Okay. So the next Wednesday will be, you just suggest me what classes will you take in next Saturday. So
The topic will be ventricular septal defect.
Ventricular, very good, very useful topic. So we'll be suggesting the book name.
So many things to discuss about the ventricular septal defect. So next topic, ventricular septal defect.
Okay, thank you so much. So we'll suggest the book or any paper if you want to suggest some.
No. For pediatric cardiology, I always suggest books. Okay.
Yes.
There is one book, Vijay Lakshmi. It is,
Mm-hmm.
I mean, for pediatric cardiology, there are certain books. For
Mm-hmm.
pediatric cardiac anesthesia, certain books. And for pediatric echo, certain books. For pediatric echo, that it is P.A. Robin. For pediatric cardiac anesthesia, it is Carol Lake and Andropoulos. For pediatric cardiology, it is Vijay Lakshmi, Parloff, Park, and Nichols. So these are the books which I used to read in my student.
Definitely.
And I also
read some of the books of.
Most of us, we have read all these books. So I will like to request all the students to just to go through for once about this chapter.